Hi, welcome to another edition of Your Health Matters with Dr. Benjamin Bryant, Chief of Staff and Chief General Surgeon for UH Conneaut Medical Center. And Doc, the humidity has gone away. All summer long we've been sweating.
Finally. You know, I heard it's supposed to get down to 49.
Tonight?
Tonight or tomorrow.
No kidding.
Oh man, how's that going to feel?
That's good sleeping weather.
Yes.
But I'll tell you what, it's Doc and I have all summer long, every time we'd come in here, it was like almost 90 degrees every week that we did a taping.
You know, I think that I saw a statistic recently said that this is the hottest summer that's ever been recorded.
Yeah. And you know, I noticed also that a lot of people are suffering from allergies and sinuses problems with this, I guess, the pollination and stuff that's going around. So I did my share of sneezing this morning.
Well, it's going to cool off and that'll subside.
Good.
And hopefully we'll get some really beautiful color this fall.
I hope we do too. I noticed you have a guest with us today.
Well, we're very fortunate to have Denise Brown take time from her schedule to come down and talk with us today, talk with the community.
Thank you for having me.
Denise obviously works here at UH. And Denise, how long have you been with UH?
I've been with UH off and on in different capacities for almost 19 years.
I know about some of those years.
Yes.
Denise used to work with me on special procedures.
Really?
Oh yeah,
Mhm.
yeah. I was really sorry when she decided to pursue other things.
Oh,
But,
well, thank you.
but then she's been with UH quite a while, and now what is your official title now?
My official title right now is Community Outreach RN, and what I do is I work in a hospital-to-home program with my partner, Lori Kingston, who is also a nurse. And what we do is we work with the patients in a new program that we're rolling out, like I said, hospital to home, and we meet with the patients once they're in the hospital, and then we follow them through home, which we'll go into a little bit more detail.
Sure. Hospital to home. So this is relatively new.
Yes, it originally started in Geneva Medical Center back in 2013, I believe, and we're rolling it out effective this past November here at Conneaut, and that's when I got the opportunity to come on board and roll out this program for our community.
Now I've obviously I've heard some things about this, some very good things about this. What is it? How does it actually work? What is it designed to do?
What it's designed to do is provide education to our patients so that they know a little bit more about what's going on with their health, their diagnosis, their treatment, signs and symptoms to watch for, so that we can kind of prevent them having to go into those acute phases, kind of catch things early so that they can follow up on their health earlier.
So they come into the hospital. So you meet them in the hospital.
Yes.
They come into the hospital and they've come in for a specific problem. Like somebody has had a heart problem, maybe they've had congestive heart failure, maybe somebody's had pneumonia, maybe somebody's had problems where their diabetes has gotten out of control, those kinds of things. So they come in and they have a reason why they came in the hospital.
Yes.
And this is kind of what you zero in on
Exactly.
as you're talking with them?
Exactly. When they come in the hospital, every patient gets assigned what's known as a LACE score, and it looks at exactly those factors.
A what?
A LACE score.
A LACE score. Why don't you tell us what that is?
A LACE score is made up of 4 components: their acuity level, their length of stay, any comorbidities or pre-existing medical conditions that are affecting their health, and also how many recent emergency room visits in the last 6 months that they've had.
Okay. Well,
And those factors then are calculated to give them a LACE score, and then a 10 or above on that LACE score triggers them that they might be somebody that I could be of assistance to.
what that's really designed to do is to figure out how sick you are, how sick you are, and how much the risk is really that you'll have problems once you leave the hospital. And then what your program is designed to do is to minimize those risks. I would assume.
Exactly.
Yeah.
Like you give a great example of the patient with congestive heart failure. They come in, their LACE score triggers that we can assist them. We try and meet our patients before they're discharged because I like them to have a face to go with the voice that they're going to be speaking to on the phone when I call them. And then we follow up with them in the home. And
I think that's very important. I think that's very important. because then when somebody calls, they know.
Yes.
Oh, this was the person I thought, so it makes it easier for them, breaks the ice, and they don't have to
Exactly.
explain a lot of stuff because you already know it.
Exactly.
That's very personalized care. That's really nice.
Well, thank you. Well, I try and make it as patient-driven and let them know that they're in control of this program as much as possible, because as we all know, when you're having a health condition, you know, you're concerned about your health, and now all these new treatments and medications, and it's a lot of concern, and it can be overwhelming at times. So I kind of like to let them meet me, break that ice, like you said, answer any questions, and then we carry it on into the home.
So you go in to see a patient in the hospital, okay, and because they're lay score, and you've seen that, and what I want, one of the things that people can conclude from this is that the hospital, the staff at the hospital here is watching.
Yes.
They're watching everybody in terms of their health and in terms of the severity of what's going on. You know, they're taking it seriously, and they're watching to see when somebody might be benefited. And the kind of benefits we're talking, we'll get into that, but the kind of benefits we're talking about are like major, okay? I mean, if you're able to intervene and provide education to people, maybe about a new medication, maybe about what really, I would assume you go in and you really explain to them what their diagnosis means.
I do.
Do you do that?
Oh, exactly. And like with the CHF patient, a great example, you know, we go in and we actually have educational modules that we do that we are starting in the hospital. It's known as EMI. It's a computer-based driven program.
What does EMI stand for? Do you know?
It's got a lot
They
of
ask, I've had it.
I can get that for you.
I've had it explained to me in the past, and somebody asked me about it recently, and I didn't know.
Yes. It's a short abbreviation for a very long name. But what it is, they're wonderful education-based modules that we assign on the computer. We try and start them in the hospital, and then I follow up with them in the home. And not everybody these days do have computers, so I actually have a computer that I will take in the home with them to follow up with them. And the thing I like about the EMI program is it's very, I always like to describe it as it's the meat and potatoes. It gets right to the point, not a lot of extra that's confusing. Gets right to the point for the patient, and it's a very user-friendly program, so patients don't have to be nervous that, oh, I'm not very computer savvy. It's very basic to use, very easy, and it's nice because during the program the patient can take notes, type in notes into it, and at the end type out a summary, which they then can take to their physician for a follow-up appointment, because as we all know, when we get to the physician's office, sometimes we get sidetracked talking about other questions and things like that, and then on the way home we think, oh, I wish I would have asked that. Well, here they have a nice printout of notes with them.
Well, you know, that implies something, and I think this is a point that probably should be made. What we're really talking about here with this EMI program and the really, quite honestly, the fantastic resource that it is,
Yes.
is people taking a more active hand in their own health, taking more responsibility for their own health, okay, which is just smart. I mean, like, you own a car, okay, and you know, if you understand that if you do the scheduled maintenance, you're going to be able to put 200,000 miles on that car, okay? But if you don't change the oil and you don't do the scheduled maintenance, okay, your engine's going to blow up, your transmission's going to go out, your brakes are going to go out. So you take an active hand in making sure your car's okay because you like to get around. Well, how much
Same
more
basis.
so than, you know, taking an active hand in your own health? Because if you are, you know, nobody is going to watch you closer than you can. Nobody. No matter how involved they are, no matter what kind of program it is, you're with yourself day to day, and you know what you do day to day, and what you do really affects your health. Now, what would you rather do? Would you rather go down to Southern Ohio and play with your grandchildren, or would you rather go into the hospital with another CHF episode? Which sounds better? That's what we're talking about.
Yes.
You know, so if you understand that, and I think most people do, and you see, oh wow, these people are giving me an opportunity to really reach in, understand what's going on, what got me in trouble, how to avoid it, you know, how to minimize all these risks to myself. I mean, you do it for your car. Why not do it for yourself?
Absolutely. You know, back in 1999, I was admitted here in intensive care, actually, with extremely high blood pressure. And I think it was in intensive care for 4 days, I think it was. Back in those days, Nancy Hutchins was, remember Nancy?
Yes.
Oh, sure.
Was in charge. She was the one that came to talk to me. Ironically, we had gone to school together, so I knew Nancy. But she explained to me what I needed to do, go home and do this and do that, and kind of relaxed me as I was ready to leave the hospital. Well, that's 1999. That's, what, 17 years ago. And I remember that. So basically, you're kind of doing what she was doing,
Exactly.
but more on another level.
Exactly, and if you like, I can walk you through a sample patient.
Yeah, that would be good.
Yeah.
Exactly what you said. It's definitely a team approach. When the patient comes in, like I said, they get the LACE score. And between nursing, the physicians, and the case management team, we get the referral, and the case management reaches out to me, and I come in and see the patient. Like I said, I like to introduce myself, kind of put them at ease, answer any questions.
Mm-hmm.
Then once they're discharged, I make an appointment with them. When I meet with them in the hospital, that I will call them to a day and a half after discharge, because I want to let them get settled into the home. If we have other services come in, let those kind of get settled in. Because it's very important for the patient not to feel overwhelmed. If they have all this coming at them at one time, it can be a little overwhelming. So I kind of like to take it a step at a time with them.
Mm-hmm.
That way they can focus on each fact as we go. I make the initial phone visit. We go into the home then. Initial visit takes...
You go into the home.
I do.
Home visits.
See, we didn't have that then.
Oh, yes, we do home visits, and again, it's at the patient's discretion. If they want home visits, phone visits, I've had people that actually just wanted me to be available via email should they have a question. They just wanted to know they had that support system, that if they had a concern. So the patient, I always want to let them know that too, that they're in control of how they want this program to run. You know, I'm here to help them in any way I can, but I want it to be in a method that's comfortable for them. So the initial home visit is about an hour and a half. That's when we really kind of get to know each other, go over their history, do the needed paperwork. And I want them to ask me any questions that they have about me and my history, because I want them comfortable with who's coming into their home, what my background is,
Mm-hmm.
things like that. And then in general, we follow our patients 30 to 45 days.
I was going to ask you how long.
Yeah, 30 to 45 days. However, we do customize that as needed per patient need. You know, some patients after a few weeks are like, you know, I'm okay. I'll just call you if I need you. Some end up expanding out to a few months. The main thing is we never discharge a patient from the program until we feel confident that the education, they're comfortable with it, that they're comfortable with any resources we set them up with, and that they feel comfortable to be discharged from the program.
And that they're back to fairly good health then.
Exactly, because at each home visit, I check their vital signs,
Mm-hmm.
and then we discuss any education, any questions or concerns. Like I said, if they get assigned ME in the hospital, I follow up with them at home and continue that education regarding diagnosis, treatment, medications. If for some reason they didn't have that assigned in the hospital, I assign it to them. So that step is never missed. They still get that education.
How do you, I mean, you spend considerable time with one patient.
Mm-hmm.
You have enough time to do all the patients that are discharged?
Well, it's any patient that qualifies for this, yes.
Wow.
Yes, yes.
You should have a busy schedule then, I would think.
Oh, yes. Lori and I are busy, but we both are of the same passion for the program, and so proud of it that we like the busyness and being able to do this for the community.
You know, Doc, I think this is a great program the hospital's doing here.
It is. I mean, you know, if you can help somebody avoid the kind of trouble that lands them in the hospital, I mean, really do something to help them with
Mhm,
that.
mhm.
What kind of a service is that? I mean,
Yeah.
that's an enormous service. Now, I would have to think that, okay, somebody comes in with whatever diagnosis. Sometimes it's just going to be bad luck. You know,
Yes.
sometimes, like if somebody comes in and they're a non-smoker, let's just say they're a non-smoker, and they do pretty, and they have a pretty reasonable lifestyle, and they come in with pneumonia. Well, they couldn't have done really, I mean, yeah, you can get your pneumonia vaccine, and should, and flu shot, it's time. Okay.
Yeah, it is, yeah.
And we're going to cover that. But even so, there are organisms that manage to evade and elude, and so you can get pneumonia, and that's not, I mean, there's nothing you could have done about that, okay? But there are other things, I'm sure, that when you're talking with the patients, you can identify factors
Yes.
that precipitated, that resulted in the patient getting in enough trouble that they had to come into the hospital. And so these things are changed. Sometimes it's a new medication, but sometimes it's something else. Sometimes it's something that they can control, I'm sure you run into that.
Oh, yes, because when I go into the home, I do a full assessment of the patient, but also the surroundings. Is there other stressors in life that might be affecting their health? Maybe not necessarily medical, but if there's other stressors, stress affects your health very much so. So that's part of this program also, that any community resources that I can set them up for, I am that liaison for them. And like I said, things to watch for. The example of the CHF patient is wonderful, because we have not only the education for the patient in regards to CHF, but we also have what's known as a CHF kit that gives them all the tools they need, the scale to monitor their weight, the measuring cups to watch their fluid, journals to log their daily activities and fluid intake. And all that's important, because those are tools that the patient needs to really monitor that health, watch those signs and symptoms, prevent acute flare-ups if possible, and they don't have to go buy those items. I can provide that to them. This program is completely free, no cost to the patient whatsoever. And so any items like that, whether it be supplies or connecting them to community resources, is a huge help, because then that gives that patient and their family time to just focus on what they need to watch for, what they need to have set up in place. And I can kind of be that middleman to take some of that load off of them, but at the same time teaching them how to handle these situations, so that once they're discharged from the program, they can carry that knowledge and those tools on.
Both of you probably could answer this question for me, and I'm kind of curious. I had pneumonia once as a little boy. Now they're saying that Hillary Clinton has pneumonia, and you mentioned pneumonia, Doc. Can you get rid of pneumonia in 2 weeks?
Well, it depends on what you mean by getting rid of. The short answer is yes, you can.
Okay.
It depends, though. I mean, what organism caused it? That has a lot to do with it.
Mm-hmm.
Some are more susceptible to treatment than others. Some are more virulent than others. There's certain kinds of pneumonia that cause, the bad inflammation in the lungs and so on. There's other kinds of pneumonia that actually destroy the lung tissue.
Really?
Oh yeah, depending on the organism. Okay, so it depends on what kind of pneumonia. That's the biggest thing. Another thing that determines it is the state of the lungs at the time that the pneumonia was contracted. Okay, that's code for saying, is the person a smoker?
Mm-hmm.
Okay, because if you're a smoker, I'm going to go off on a rant here, just a short one, just for a second. Okay, if you look into pulmonary physiology, it's fascinating. I mean, really get down into what's going on. It's fascinating. There are, 5 different levels of protection mechanisms that the body has to protect the lungs. Because if you think about it, the lining of the lungs is in contact with the environment. The air is in contact with the environment. Anything that's in the air, smoke, particles, bacteria, what have you, is in contact with the lining of the lungs. Okay, so the body has to have a way to protect itself, and there actually are 5 different tiered levels of defense that the body has, and smoking systematically takes out every single one of them.
Is that right?
Oh yeah, it's no joke. It is no joke. People who smoke, they can't protect themselves against environmental stuff like bugs nearly as well. And if they do get pneumonia, they really don't, the state of the tissues is such that they can't really fight it off as well. So it's going to be more severe, it's going to last longer, it's going to take longer to recover. I mean, anyone who takes care of these patients knows this. You know, from a surgical point of view, if I have to do a procedure for somebody that's going to require a general anesthetic. General anesthetic means that you go on the ventilator, you go on the anesthesia machine. You know, intravenous sedation, no. But general anesthetic, that means you're completely out, you're on the ventilator machine, and the anesthetic is delivered that way, inhalational anesthetic, okay? The difference in the lung function after general anesthesia
Right.
in patients who smoke and patients who don't is enormous.
Is that right?
Oh, people who smoke, they produce all these thick secretions, they're much more likely to get a pneumonia, they cough and cough, you know, which hurts your incisions and so on.
Right.
So you're really setting your, you know, and people aren't stupid, everybody knows this, and I'm not lecturing people. That's not what this is about. What this is about is information, you know, things to think about.
The question, the reason I guess I asked you, they're saying, well, Mrs. Clinton can get back on the campaign trail within a few days, and I'm thinking, geez. And of course, we don't know what kind of pneumonia it is. So
you know, there's all kinds of problems there. This isn't strictly medical, it's political.
Oh, absolutely. Yes.
It's political, I mean, but I don't know, I mean, this, I don't know, I mean, it just seems logical. I mean, this person's running for president, and people, you know, is her health, what's her health like, you know?
I'd really like to know, for both of them. I read a
both of them.
doctor's article yesterday that said, you know, when you hit 70 years old, like Trump is, things start to go south. And we should know exactly where he's at 70. They're the two oldest candidates ever to run, you know.
And the thing that bothers me about the Clinton side is that they hide it.
Oh, there's a lot of hiding.
Yes.
You know, they deliberately didn't go to the ER because they didn't want anything. Now, why all this secrecy?
Right, exactly.
You know, basically, that's a message to the American people. We don't trust you, and we don't want you to know.
Exactly.
Well, gosh, that doesn't make me feel very warm and fuzzy.
Good
I mean,
stuff.
I don't want to go political because people are going to go nuts.
But it is the truth. It is the truth.
But
We
I just
deserve
think
the right to know.
honesty and
Yes, I agree.
transparency from both sides you should have.
Absolutely.
Exactly.
But I don't know. I mean, I don't know. I mean, the state of her general health. I don't know the state of her lung health. I don't know how severe the pneumonia was. I don't know what the organism was. I don't know. But I mean, you know, if it's severe enough to make you faint, I mean, it seems like being back in the game as stressful. I mean, what's more stressful than running for president? You know, to be back in that game in 4 days. I don't know. I mean, you know, you might say good luck with that. You know, I don't know.
I know, yeah. Good stuff. That's good stuff. Back to you, Denise.
Folks, that was not a political statement. It was just observation. That's it.
Great example of how hospital home could follow up with her.
Perfect. You know, if she had come to UH, Denise would follow up with her
Yeah.
and make sure she stays out of trouble.
That's what your job is.
There we go.
So anyway, you have been doing this for quite some time, being a nurse, an actual
Yes.
nurse.
Yes.
So when you go into the house, you know basically what's going on and what
Yes.
needs to be done. Have you ever had to call in, like, say, a doctor to, you know, I think we might have a little problem here. I mean,
Yes. Anytime there's any kind of a acute change with the patient, I talk to them first about what's going on with them. And that's a main point about the program. I'm glad you brought that up. Anytime we reach out on behalf of the patient or the family member, whether it be to a physician or a resource of some sort, the patient always knows. We're always on the same page. They give us their consent to do so. Because I think, like you said, communication and transparency is very important. So I'll contact the physician, and sometimes then once the patient's better, if they have follow-up, I'll have the patient contact the physician, so then they know how in the future when they're out of the program, okay, you know what, I have this you know, I'm having a weight gain, I need to call my physician, you know, maybe my CHF is flaring up again, or, you know, I need to elevate my fee. Any education we do, we want that to continue on. But yeah, we reach out to physicians. I've reached out to community resources if patients have issues as far as like being able to take care of tasks at home, get groceries and things like that. There's a lot of wonderful community resources out there that I'm networked with that are just wonderful and invaluable to our community that I can connect patients with, because a lot of these are not very well known. People are, oh, I didn't realize that was there. So it's a great networking opening for the patients and these resources to help in many different ways.
That's terrific.
Yeah.
And a lot of them are at little cost or no cost. Because along with caring for the patient, it's also caring for the families. Because as we know, when we have our own loved ones are ill, that affects all of us, and we need to make sure that they're okay. So it's kind
Sure.
of not only educating the patient, but also the family, and having these resources set up. So say like it's your mother or father, but now you've got to go back to work. You feel comfortable that, okay, I know this agency's checking in on them, or they have this alert that they can call. So it's really kind of a whole approach with the whole family, not
Yeah.
just the patient.
Well, that's certainly, for all those people out there that are watching this, should give you some kind of feel of being more relaxed, knowing that you have people like Denise and staff out there watching over you and making sure that you can get your lifestyle back to pretty much normal, And it doesn't happen overnight. It takes some time.
Yeah, you had said that it was a free program?
Yes.
Do you mean it's covered by insurances, or how does that?
No, it's completely free. It's part of our community benefit programs.
Wow.
Yeah, so we don't.
What you do,
What I do, yes.
Okay.
Any of my visits, whether they're home, phone, any supplies that I provide the patient are completely of no cost to the patient. However, follow-up physician appointments, things like that are a whole different spectrum. They go per usual through the insurance company, but anything that I do, completely no cost to the patient.
I really appreciate you asking that question, Matthew. That is an example of the commitment that University Hospital's Conneaut Medical Center has to this community. They do this for the community at no cost.
Mm-hmm. Mm-hmm.
Okay, and sometimes folks are of the mindset that, they're watching me, they're investigating me, and then they're going to tell me I did this wrong and that wrong and so on and so forth. Folks, we run into this. That's not what this is, folks. That's not what this is. Nobody likes coming to the hospital. Nobody likes getting sick enough that you got to be hospitalized. I mean, gosh, and what you've got here is a team that really knows what they're doing. That's really, a lot of work has gone into providing the different kinds of education that's done, that's tailored for you, and it's something that you can use to keep yourself enjoying life the best that you possibly can. That's what this is. So, wow, I didn't realize, I learned a lot here today about this program.
Me too.
I didn't
even know it was here, to be honest.
Yeah, I didn't realize what a tremendous benefit it is to the patients. So folks, please make use of this. I mean, if let's say that there's some people out there who are watching this who are saying, whoa, the last time I was in the hospital, and the last time my mom was in the hospital, this or that. If they want to know more, who do they call to find out about this?
You can call either hospital, and if you're in the hospital, there's flyers that we have sitting out. We also have them in the local physician offices also. But call either hospital and just say, I'd like some information hospital to home, because
hospital to home, folks.
Yes.
Hospital to
Yes.
home. It's the hospital to home program. So you're saying they can call the main number
Yes.
of the hospital, which, is just the main number of the hospital.
Yes.
Operator answers and they say, I would like information about hospital to home.
Yes, and they will get connected to, at Conneaut Hospital, they will get connected to my phone number. And if I'm not there, there's a voicemail. Please leave a message. I'm more than happy to call you back. And at Geneva, it would be Lori Kingston would be the voicemail
Lori.
that you'd be connected to.
So you're based out of here, out of Conneaut?
I do have space here and then we also have our main office in Geneva.
Okay.
I mean, in Ashtabula also, we have offices in all three.
Okay.
But with that being said, it is mostly just hospital, but I have had actually community members reach out to me that, hey, I know somebody that could benefit from this program, and I've opened programs like that just for them. It doesn't necessarily have to be from the hospital, because if I can help somebody prevent it early, I'm happy to do whatever I can for you.
Now, let me ask, here's a patient, lives in Ashtabula, okay, and decides that they would like to, if they need medical care, they're going to get it at Conneaut or Geneva. Even though they live in Ashtabula, they would prefer to get it through university hospitals, okay? And so you have a patient here in our hospital who lives in Ashtabula, okay? You're still going to follow up and provide this program to them, even though they don't live in Conneaut.
Oh, yes, this program is for the entire county.
The entire county?
Yes, I travel all over.
Pierpont?
Oh, yes, Pierpont, Andover, Ostenburg, Rock Creek. Yes, it's not a problem. I'm more than happy to go anywhere that they need me to.
Wow, Jefferson?
Oh, yes, yes.
See, there you go.
There
you go.
Yes, no, but good point. It's not just Conneaut focused.
Excellent. Great program.
Thank
Very
you.
good program.
Thank you.
Go ahead.
I think there's another follow-up show needed for, she had talked about community resources. And I see a show that even if we do it without Dr. Bryant, or, we should do a program that we can talk about your community resources that are available to us.
I'll tell you what, Matthew, that's an excellent suggestion. I'll get with Denise and we'll figure out who should be here for that.
Yeah.
It's a great idea.
I
It's a
would
great
love
service
to
to
do
the
it.
town. We'll do that,
Yeah.
definitely.
I just got asked
Thank
the
you.
other day by an elderly lady that, she has things around her house that need done. She's 97 years old. She can't do them, obviously. And she wanted to know if she had heard about Conneaut Human Resource Center has handymen that'll come to your house and
Yes.
do that
Mhm.
work for you.
Yes.
Free,
Yeah.
Mhm.
So stuff like that is available out there. You're right, very right, Denise, that we
Matthew, that's
should
an
do
excellent
that.
idea.
Yeah,
We'll do that for sure. We'll
yeah,
do that.
good deal.
Okay.
Well, I'm very informed today, Denise. Thank you so much for coming in.
Thank
See,
you for the
it
opportunity.
wasn't that hard, was it? All right.
Now, this is a terrific program, and Denise, we really appreciate you taking the time to talk to the town about it.
Absolutely.
Thank you for the opportunity.
Absolutely.
I appreciate it.
Okay.
Always remember, your health matters, and we'll see you again next week.